Committee will come to order. I thank the witnesses for waiting, and I understand that at least two of our guests have a meeting at the White House for actually an exercise that's going on right now. So we're going to be very brief and adhere to the 5-minute rule, and hopefully we'll get you out of here in just a couple of minutes. If I can speak to Dr. Jolly and Dr. Vanderwagen, let me address my questions there. We were talking about earlier how we can better coordinate Homeland Security and HHS grants with respect to pandemic flu that could be also beneficial in other areas. Let me ask this: how can we better coordinate all public health grant money, especially those that come from HHS? Again, my understanding is that not all grants have common goals and performance measures. My question is there a system in place at HHS to coordinate things like goals and performance measures, especially when there are multiple grants, perhaps some from CDC, some from the ASPR, dealing with the same topics such as pandemic flu?
Yes, sir, Mr. Chairman, and indeed there is a fairly well-defined process of planning that goes into the grant guidance that we provide, remembering that the Centers for Disease Control's investments are more targeted at public health types of interventions and public health programs at the community level, where the hospital preparedness dollars are really targeting the medical side of that. Our interest here is to see the public health and the medical community to act in concert on these activities. And unfortunately, in this country, we had seen a large gap develop between public health and medical communities. And one of our goals is to bring that into greater proximity. Accordingly, we are not only trying to align the expectations from the grants, recognizing that public health is slightly different than clinical medicine. We're also now trying to bring our grants into the same time sequence as the DHS grants, so that the states and communities are looking at the whole grant package in the same time frame, rather than looking at one in March and then one in August and then maybe one in October. And so those are the active steps that we're taking. A, meeting before we issue guidance to assure that they synchronize, and secondly, to try and fix the timing on our public health and hospital grants to align more closely with DHS in their timing.
And to add on to Admiral Vanderwagen's statement, Mr. Chairman, the timing and sequence are quite important, and also the content of the grants. We have an active effort now growing within DHS and HHS to communicate among those that are responsible for the grant guidance at one agency, so that the other agency knows what that grant guidance is and can help to harmonize that. And one of the roles, as you know, our office is a relatively new office in health affairs. One of the roles of our Division of Medical Readiness is to take a look at the DHS grants and also coordinate across the HHS grants and try to harmonize those. And it's going to be a stepwise process over time, but I think we can make some real improvements in that.
Good. Well, I plan to pay particularly close attention to that, and so that'll be part of our oversight as we go forward. I think it's beneficial for both departments and for the country, and ultimately the states and our citizens are going to benefit. Very quickly, for DHS and HHS, once again, when we conduct exercises, and we spoke about exercises earlier here, and practice and making sure that we're ironing out the issues before they actually occur. When we conduct exercises, it's important to conduct them in the most realistic way possible, and to the extent we can use current requirements to show us how well we might do in future situations. During a pandemic, DHS and HHS will be the lead federal agencies in terms of managing the response, as we discussed earlier. I believe that we should test our systems now, using, for example, seasonal influenza as a proxy for pandemic influenza. So my question for you, Dr. Vanderwagen, is why don't you take this year's influenza season and make a concerted effort to see how many people we can vaccinate in the shortest period of time, basically pretending that seasonal influenza is actually pandemic influenza. Can you get HHS programs such as the National Immunization Program to step up and work with other HHS entities and systems to exercise in this way?
Yes, sir. And in fact, in 2006, I live in Howard County up the road here, and the state of Maryland was test driving its ability to deliver vaccines in an event of a pandemic by using the seasonal flu as the test bed. And essentially, they had a drive-through approach so that we could maintain social distancing and yet provide access to vaccines for the population. It took me 3 hours to get my vaccine, but it worked. And we're promoting more of that kind of use of vaccination opportunities as a test drive of how they would use mass prophylaxis in the environment of a pandemic flu. I think that is a capital idea. Some states have done it. We're trying to promote it more holistically to all states. I think Dr. Gerberding on Wednesday this past week, a week ago, when she made the announcements regarding this year's seasonal flu, that was one of the points that she tried to make. So I think we're on the same page with you, sir. It remains for us to demonstrate to you how that went off.
Good. Well,
and I would agree that some of the operational elements of vaccinating individuals and some of the other things, the countermeasure issues, can benefit from those types of exercises. That's a very good idea and something that other states have tried and will continue to refine. And then some of the larger exercise issues, we have plans within our principal federal official group to exercise within that group and then lead that into a series of leadership level interagency exercises and to culminate in another cabinet level exercise over a period of time as the schedule develops.
very good. Well, I see benefits across a range of areas in conducting such an exercise. So, well, I thank you for your answers, and I now recognize the gentleman from Texas for 5 minutes for questions.
Thanks, Mr. Chairman. I'll be brief. We have a vote in, I think, 15 minutes. So, Ms. Steinhardt, you mentioned in your testimony certain gaps that are currently in terms of our readiness or preparedness. I would like, if you could, to focus on sort of the highlights of those gaps and how we can do a better job.
Yes, I'd be happy to. Ones I think that I wanted to highlight in particular, first, the fact that there are in the National Strategy and Plan, there's no mention of the resources that are going to be required to carry out the plan. There are well over 300 action items in the plan. Dr. Van de Wagen and Dr. Jolly mentioned earlier the vaccine program and the supplemental appropriations, but there are many other actions that are called for in the plan beyond those that are covered in the supplemental appropriations, and there's not even an estimate of what would be entailed. So that's one important gap, and certainly from an oversight perspective, it's really critical. Another gap that we were particularly mindful of was the fact that state and local and tribal entities weren't involved in actually producing the plan and preparing the plan. They are responsible for close to 100 of the action items, either as the lead or in some sort of support capacity, and yet they weren't consulted when the plan was being developed, and that, I think, is something that needs to be addressed. And then the plan itself, within the plan, there's no institutional process for updating it as new events unfold, as we learn from exercises and so on. There's no process to update the plan or to monitor progress on a regular basis. So those are, I think, there are several others that we point out in our report and statement, but those are the ones I would highlight.
Thank you. And I do want to thank the witnesses again. I think we have made some progress, and as Dr. Van der Wagen mentioned, I think we are partners in this, and so I look forward to working with you to make sure we're prepared. Thank you.
I thank the gentleman, and with that, no further questions. I thank the panel for the testimony of your presence here today and for the work that you're doing on behalf of the country, and look forward to the continuing oversight in this area in partnership with you in this effort. Thank you very much. With that, the first panel is dismissed. And if we can have the second panel come to the front.
What's been 90 degrees out there? I'm starting to think y'all right about global warming.
So that's what it took to convince you.
It's one thing in Austin, Texas.
Very good. Well, gentlemen, thank you for being here. I want to welcome the second panel of witnesses. Our first witness is Dr. Anthony Cirillo, the Chief of the Center for Emergency Preparedness and Response in the state of Rhode Island Department of Health. He's also a practicing emergency room physician. In addition to that, prior to his present post, he was Chief of Emergency Medicine at Pawtucket Memorial Hospital in Rhode Island. Welcome, Dr. Cirillo. Our second witness is Dr. Peter Schultz. Dr. Schultz is the Director of Communicable Disease Division of Emergency Laboratory Response and Chief Virologist of the Washington State Laboratory and Hygiene. He is also a Clinical Associate Professor of the Department of Medical Microbiology and Immunology at the University of Wisconsin-Madison. Welcome. And our third witness is Dr. Michael Caldwell, Commissioner of the Dutchess County Health Department of Poughkeepsie, New York. Dr. Caldwell is the immediate past president of the National Association of City and County Health Officials. He's also an internal medicine physician and a public health officer with 12 years of experience in local public health practice. Our fourth witness is Dr. David Lakey, Commissioner of the Texas Department of State Health Services. We want to welcome all of our panel here today. I thank all four of our witnesses for their service to the state, their various states, and to the nation, and again for being here today. Without objection, the witnesses' full statements will be inserted into the record. I now ask each witness to summarize his statement for 5 minutes, beginning with Dr. Cirillo.
Mr. Chairman and members of the committee, I'd like to thank you for allowing me to testify today to discuss the current successes and ongoing challenges in planning and preparing for a pandemic influenza event. I'd like to share with you my dual perspective as both the coordinator of public health emergency preparedness for our nation's smallest state and as a practicing emergency physician in an urban community hospital. Today, I can share with you that although significant progress has been made in preparing the public health and healthcare sectors for response to a pandemic, there is still considerable work that needs to be done, and there are challenges both of scope and depth of preparation that will need to be addressed in order for our country to meet the challenge of a pandemic event. In Rhode Island, the Department of Health serves as the sole public health agency within the state, as there is no other city or county-based public health infrastructure. As such, the department is responsible for the administration of all traditional public health programs, both promotional and protectional. The Center for Emergency Preparedness and Response oversees all public health emergency preparedness grants, including the CDC Public Health Emergency Preparedness Grant and the Hospital Preparedness Program grant administered through the Office of the ASPR. Under the leadership of U.S. Secretary of Health and Human Services Michael Leavitt, who issued a challenge to prepare for a pandemic during his state visits in 2006, Rhode Island undertook a spectrum of activities. The successes that have been achieved in pandemic preparedness in Rhode Island have come, to a great extent, due to the strength of our partnerships and working relationships within the state and the New England region. In Rhode Island, we have strived to develop an integrated and coordinated system for the public health and healthcare sectors to respond to any public health emergency, including a pandemic. Ongoing coordination with our hospitals through the Hospital Preparedness Program facilitated the establishment of 10 healthcare coordinating service regions in the state in order to respond to the needs for healthcare during a pandemic. Stockpiling of critical supplies at the state level, including patient care equipment, personal protective equipment, ventilators, and other support materials, has begun in order to provide an initial cache of medical equipment needed to supply alternate care sites during a pandemic. Outreach and risk communication messaging in the senior community, other special populations, and the general public through brochures, newspaper inserts, classroom materials, and public service announcements has already occurred. Regional interstate coordination in pandemic preparedness has also occurred among the 6 New England states and the state of New York. Each of these states has participated together in work groups focused on a number of pandemic topics. This collaborative effort resulted in a 2-day summit and a multi-state tabletop exercise held to coordinate the interstate response to a pandemic. Despite the progress that I have described, there is still considerable work to be done. Ongoing challenges include, number one, inadequate funding and resources to purchase enough material to ensure care of anticipated numbers of patients during a pandemic. 2, shifting and evolving federal grant priorities related to pandemic flu and overall public health preparedness, which create inefficiencies in program management. 3, the disincentives to the purchase of antiviral medications, Tamiflu and Relenza, due to exclusion from the shelf life extension program of state-held supplies of these medications. Now, as an emergency physician, I have personally witnessed the increasing demand for medical care being placed on hospital emergency departments. With the number of uninsured Americans now in excess of 47 million, more and more individuals do not have appropriate access to medical care. In the absence of a medical home, people who experience injury or illness will seek care in the one environment where they know they will never be turned away, and that is the emergency department. However, emergency departments today are overcrowded, surge capacity is diminished or being eliminated altogether, ambulances are diverted to other hospitals, and the shortage of medical specialists is worsening. According to data recently released by the CDC, emergency department visits are at an all-time high of 115 million in 2005. That was an increase of 5 million visits in just 1 year alone. And from 1995 through 2005, emergency department visits increased by 20%, while the number of functioning and operating emergency departments decreased by 9%. Because of the extraordinary demands that a pandemic will place on the healthcare delivery system, it is imperative that we are able to engage the general public and encourage them to assume responsibility for their own preparedness. Just as the saying goes that all disasters are local, so is the response to a disaster. In the truest sense for a pandemic, this means that preparedness must begin with individuals, families, neighborhoods, and communities. It is critical to the successful response that we develop a culture of preparedness in this country in order to ensure that those who have the means to prepare for themselves do so. If we can accomplish this, then the burden of response on government will be reduced so that scarce resources available can be shifted and allocated to those who are most at risk. In conclusion, I would like to share with you the following closing thoughts. States and local health entities are willing partners in the development of systems to respond to a pandemic event or other public health emergency. However, the resources and support of the federal government are essential to creating and sustaining the capability and capacity required to prepare for and respond to all public health emergencies. Incorporating new grant requirements and updates to national planning documents related to a pandemic or other public health emergency requires considerable time at the state and local level and utilization of resources in order to effectively reach the entire healthcare responder community and the general public. Therefore, it is critical that all federal preparedness programs related to pandemic or other public health emergencies be more closely aligned and coordinated so that we at the state level can more effectively develop an appropriate response to all public health emergencies. Mr. Chairman and members of the committee, I thank you for the opportunity to discuss these important issues with you today and would be happy to answer any questions you may have.
Thank you, Dr. Cerullo. With that, I want to recognize Dr. Schultz to summarize his statement for 5 minutes. Welcome.
Thank you, Mr. Chairman and members of the subcommittee. I'm here today representing the Association of Public Health Laboratories, of which the Wisconsin State Laboratory of Hygiene is a member. As the name implies, the APHL is the Association for State and Local Governmental Laboratories that perform testing of public health significance. In the event of an influenza pandemic, it is currently highly unlikely that a well-matched vaccine, the best countermeasure, will be available when a pandemic begins. Instead, current national plans call for initiation of drastic community mitigation measures augmented with distribution of limited antiviral supplies to impede the pandemic's progress. This will require documentation of the emergence of a novel influenza virus and confirmation of sustained community transmission of the virus using highly specialized laboratory testing performed solely by a public health laboratory. Maintaining this capability and response readiness will be a challenge for the public health laboratory, given limited and now declining federal support and a greatly expanded role well beyond diagnostic testing in emergency preparedness and response. Public health laboratories are the leaders in laboratory preparedness and response efforts, a key national security asset that serve as reference laboratories in the National Laboratory Response Network. These laboratories are capable of performing highly advanced, accurate tests that allow rapid detection and identification of biological agents of public health significance, including seasonal influenza strains and newly emergent subtypes of influenza with pandemic potential, such as the H5N1. This testing capability is critical to state and national influenza surveillance. Furthermore, because of the potential introduction of a novel virus into the United States from international travelers, CDC now requires that states conduct this surveillance year-round. The public health laboratory must also work closely with private sector laboratories that provide diagnostic testing to support patient care, with agriculture and veterinary laboratories responsible for monitoring influenza within animal populations, and with a host of other public health and emergency first responder partners. Maintaining these networks is resource intensive and difficult to accomplish without adequate funding. The public health laboratories are heavily reliant on the expertise at CDC, in this case the CDC's Influenza Division, to assist in outbreak response and to develop new methods for detection of influenza. The CDC is also critical in helping facilitate collaboration among laboratory partners to ensure adequate testing surge capacity is available for pandemic response. DHS has created the Integrated Consortium of Laboratory Networks to address coordination and integration of the different federal level agency networks. However, the work of the ICLN has not yet been apparent to the frontline public health laboratory serving an all-hazards mission with diminishing resources. Traditionally, public health laboratories have relied on state resources and minimal allotments from the CDC's epidemiology and laboratory capacity funding to support laboratory influenza surveillance. Although further supplemental funding has been appropriated for pandemic influenza preparedness, to date, few public health laboratories have benefited from these funds, despite increased expectations for rapid testing and year-round surveillance. Only because of funding from the CDC's Public Health Emergency Preparedness Program has substantial laboratory emergency response infrastructure to respond to bioterrorism, pandemic influenza, and other public health emergencies been developed. However, this funding has also begun to decline. In conclusion, given the critical role of the public health laboratory in detecting and monitoring both seasonal and novel, potentially pandemic strains of influenza, as well as other potential public health threats, the substantial testing capabilities and capacities that have been developed and that I've described in my written testimony needs to be sustained. And future improvements in diagnostic technology and networking activities such as communications and information and data sharing among laboratories and with response partners need to be made. Without sustained federal funding from CDC and other agencies, our ability to fulfill this pandemic and all hazards public health and national security mission will be compromised. I ask your help in not letting this happen. Thank you very much, and I'd be glad to answer any questions.
Very good. Thank you, Dr. Schultz. Appreciate your testimony. And the chair now recognizes Dr. Caldwell to summarize his statement for 5 minutes. Welcome.
Good afternoon, Chairman Langevin, Representative McCall. It's a pleasure to be here to speak to you on behalf of all the local departments of health in our country. I come from Dutchess County, New York, the place and the home of Franklin and Eleanor Roosevelt. So greetings from there, and please, if you do come to visit, please let me know. You know, Franklin Roosevelt won the presidency 4 times. Did you know that his hometown of Hyde Park in the county of Dutchess never voted for him? Never. It was sad for Franklin, and I'd tell you it's kind of a microcosm of what it's like doing public health in Dutchess County. It's a challenge. We have a challenge in our county, and we have a challenge in our country. The combined efforts of my colleagues in local public health departments in first response will determine the initial as well as the ultimate impact of an influenza pandemic on the people of the United States. But health departments are planning, but the success of those plans relies on the crucial linkages that have been built between our local public health departments and a range of governmental and community partners at the local level, including also the state and the federal level. The relationships among these responders in many disciplines across our communities, regardless of who their federal counterparts may be, they are growing more robust, they're better coordinated, and I really want to answer your question that you asked very simply, are we more prepared? And the answer is yes. Today, I bring you a story of progress, a story of success at the local level, but clearly an opportunity to improve, and an opportunity that I think needs to be led and demonstrate the leadership at our federal level. There's no question that local emergency preparedness has evolved into an all-hazards approach right now. It requires communities to assure that all capabilities are necessary to respond to a wide range of emergencies. Our health departments do not and cannot stand alone. All of our planning must be integrated with all of our partners and first responders. And one of the great advances we've had is the strength and mandate of the National Incident Management System, the Incident Command System. Just this past week, I spent 3 full days in Poughkeepsie, New York, completing the ICS 300 training with colleagues from emergency response, police, fire, EMS, water plant operators, state emergency management officials, state troopers, public health nurses. We really have made progress in that area. In Dutchess County, we've learned this new language and we've put it into effect. But more really needs to be done. We need to strengthen these opportunities, we need to strengthen this planning, and we also need to exercise and evaluate. It's very important to know that the greatest strength that we provide at the local level is the strength of our American workforce. Our astute clinicians and the partnerships that we have with our colleagues, our trained healthcare professionals, our alert hospitals, these effective partners are forged between these entities and our capable colleagues in local public health. Ultimately, the local public health departments are the boots on the ground element of our nation's disease system. My health department receives and responds to thousands of infectious disease reports each year. After September 11th, our county's hospitals and emergency departments began reporting on our hospital emergency response data system. We also have partnerships not only with our healthcare providers, but veterinarians and pharmacists. Soon, we will be also reaching out not only to schools and school nurses, but colleges and businesses. We are actively engaged in cross-training our entire community to be aware and be prepared. We are also providing and improving our community alert network, our reverse 911 system of communication. We think that is one of our major roles and something that we are working hard to improve. Ultimately, we believe that we need a strategy of implementation and not just planning. And the implementation happens at our level. We need the resources, we need the people, we need to exercise and evaluate, and we need to improve. We need sustainable and a growing commitment from the federal government. Unfortunately, we have seen mixed messages from our federal leadership. There does not appear to be adequate coordination or cooperation between the planners of Health and Human Services and the Department of Homeland Security. We have seen clear examples of us being left out of the development of the National Response Plan. It makes no sense to develop a plan among federal officials and then just tell the local officials how it's going to work without integrating them and involving them in the first place, and also including with those development of those plans the understanding of how it's going to be implemented and carried out. We are hopeful that federal colleagues of ours will hear this message, and as we improve the future planning and the future versions of these plans, we will be able to get feedback from our testing. And we're going to learn nothing unless we exercise and test our plans and constantly revise them. So we're hopeful today by you having this hearing. We want to thank you for it, the recognition that we have made progress, that we need to do better. We need to continue our conversation. And we look to the federal government to be able to serve as an example to us at the local level. If we see that there's miscommunication and miscoordination at the federal level, that impacts us at the local level and makes us do our job, makes our jobs more difficult. If my emergency response department and my health department have different planning tools, it makes it more difficult for us to integrate those tools. Overall, our community and families depend on us for leadership. They depend on us for competency, for guidance, but most importantly, for action. We should not and we cannot let them down. Public health preparedness is a long-term challenge, whether it's for pandemic influenza or any other emergency. We obviously cannot do everything at once, but we are making great strides. I'm pleased with it. And I want you to know that local public health departments are integral in both the planning as well as the execution of any pandemic influenza efforts. Thank you very much.
Thank you, Dr. Caldwell. Before I go to Dr. Lakey, there's a vote on right now. My intention is to go to Dr. Lakey for your statement, and then we will recess for about 20 minutes, come back for a very brief round of questions, and then conclude. With that, I recognize Dr. Lakey for the purpose of summarizing your statement for 5 minutes.
Good morning, Chairman and members. My name is David Lakey, and I'm the Commissioner of the Texas Department of State Health Services. And I want to thank you for this opportunity to testify on the progress and the challenges we face in Texas preparing for pandemic influenza. In order to understand these, you have to understand something about the Texas structure. The Governor's Department, or Division of Emergency Management, directs overall disaster response in the state of Texas. Department of State Health Services, however, is the primary agency for coordinating health and medical preparedness and for coordination of pandemic flu prevention, detection, response, and recovery. We have significant experience in Texas in disaster response. However, pandemic influenza response is unique, as has been outlined here earlier today. There are issues related to the geographical spread. There's issues related to the length and duration of the pandemic, and thus, pandemic influenza is not just a medical issue, it's a societal issue as we respond. One of the strategies in public health to respond, one of the cornerstones is called social distancing, basically keeping individuals apart so they do not spread the disease one to another. And this includes closing schools, canceling public events, working from home, and these are hard decisions. These decisions are made locally, and we have to work as a state with our local partners to make sure that there's continuity in how these decisions are made. We also have to address worker safety issues to make sure that the first responders are safe when they respond to individuals with influenza so they do not become the next victims. We also are struggling with how do we continue our operations to make sure we have continuity of operation plans. In a situation where you have 30 or 40% of workers absent, how do we continue to keep government functional, businesses functional, utilities that are being provided? We also have to look at hospital surge capacity, especially intensive care surge capacity. This will be a major stress on the hospital system and the medical system during a pandemic. Thus, with that background, we have been working for several years now on how do we respond as a state to this threat. And we've done this in collaboration with many stakeholders, our local partners, our federal partners, so that we can develop comprehensive plans in the state of Texas for disaster response. This is a part of the overall state disaster preparedness plan, and we've also developed a more comprehensive 122-page guideline for pandemic influenza that outlines what we specifically need to do in each stage of the pandemic. We've worked on to make sure that we can allocate and distribute the antivirals if they are available. We have worked to make sure that we can vaccinate individuals very rapidly, as was discussed earlier today. And we have made sure that we have set up a statewide laboratory diagnostic system, part of the laboratory response network that was discussed just a minute ago, so that we can rapidly diagnose individuals with influenza in a matter of about 3 hours after the samples are sent to this system of 10 labs across the state of Texas. We've also provided guidelines to the local health departments so that it is an integrated response in Texas, and have developed information toolkits for healthcare providers and community leaders. A couple other projects we have been working on this summer have been the development, working with the CDC to look at our laws in the state of Texas to make sure we do have the right legal infrastructure during a pandemic. And we've been working with state agencies across Texas to make sure that there are continuity of operation plans in all agencies and state government, and that there's some consistency in HR policies throughout state government when a pandemic occurs. We believe that there are really 3 critical components of the strong response to pandemic influenza. First, we need to build and maintain a strong public health system. This is locally, at the state, and at the federal level. We need to create partnerships between the federal, state, and local levels, and international partners and private partners in this response. And we need to recognize that there's differences between local areas and maintain the flexibility that allows states and localities to act effectively and efficiently during this threat. It can't be overemphasized the importance of a strong public health system. Texas's success has been due to building on the public health system and using an all-hazards approach for all types of threats, so we can identify them, monitor them, ensure that we can respond effectively, and that we communicate with our public and our private partners during this time period. A couple of the strengths, or examples of the strengths that have occurred in Texas include the development of our Strategic National Stockpile Operations Plan that has been reviewed by the CDC, and it received a very high score this last month. Our plans have had favorable recognition by the CDC. We learned during Katrina and Rita the need for a multi-agency coordinating center during any type of disaster, where we bring the individuals that need to take care of the logistic components of ICS, Incident Command System, together, all incident command systems, so we can have a coordinated response. We've established a surveillance system for all viruses, respiratory viruses, so we can identify them early. And we've been coordinating with our CDC partners and other partners at the border ports of entry and at major airports. And finally, we've developed a public health information network so we can disseminate information quickly to our partners throughout the state of Texas. Again, it's important to have a very strong public health response. It's also important to have federal, state, and local partnerships. This is not something that the state can do on its own, and this has to be coordinated through all these different partners. This needs to be sustained. There has to be sustained commitment and consistent direction from the federal level in order to ensure that these programs that have been developed continue. This is an ongoing threat, and in order for us to be successful, we have to have integration across all levels of government and coordination across jurisdictional lines. We understand the need for partnerships in Texas. We have very large cities. 4 of the 20 largest cities in the nation are in Texas, and we need to coordinate from the state level with these cities. We have sea and airports that are among the busiest in the country. We need to partner them as part of this disaster preparedness. And over half the U.S.-Mexico border is in our state, and over 1 million individuals cross the border legally every day, and thus we need to work in partnership with our Mexican colleagues. We also believe that there's importance for flexibility in the overall response, that there's flexibility in preparing and responding to a pandemic, and that different states, different localities have different challenges that need to be addressed, and we need to have flexibility in the use of human, financial, and medical resources. In Texas, Texas is a local controlled state, and so many of the decisions for pandemic influenza will be made at the local level, and they need to have the flexibility to be able to respond appropriately. About 95% of all the funds that come to Texas go to the local health departments to ensure their ability to respond. In summary, as I said, there are 3 priorities that I think are critical. One is to have a strong public health system. The second is to have consistent partnerships between the local, state, federal, and international partners. And third, we need to have flexibility, and it's essential in order for the state to respond appropriately. Federal funds allow Texas to build an emergency response infrastructure to enhance our overall preparedness programs, and it needs to be sustained in order for these programs to continue. And we appreciate the investment from the federal level and look forward to a sustained partnership, and I appreciate your time today.
Very good. Thank you, Dr. Lakey. With that, as I said, it's my intention to recess for about 15 or 20 minutes. We have 2 votes. We'll come back for a very brief round of questions.
Thank you.
Thank you very much. Committee stands in recess.